Hi, everyone. Thank you for coming again. This is session 2 of our learning collaboratives on the social determinants of health and integration into clinical practice. Second session, we'll be focusing on SDOH program creation. We'll be going over a case study and some of the frameworks utilized in another case study as well that looks at how this stuff really works on the ground and some of the protocols and frameworks you can use at home.
Okay, and then hello everybody, my name is Fide Pineda and I am the TTA manager here at NCHPH. And it is a pleasure for me to be joining you all today. I'm just going to go over some information about the National Center for Health and Public Housing. NCHPH, the mission of NCHPH is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing training, any range of technical assistance. NCHPH is also a project supported by the Health Resources and Services Administration and is a national training and technical assistance partner that is 100% financed by this grant. The information presented today are those of the author only. Before we continue, this is just some background information about health centers that are close to public housing. As of 2021, health center data, there were 1,373 FQHCs that served to 30 million patients, 458 FQHCs that were also in or immediately accessible to public housing that served to 5.7 million patients, and 108 public housing primary care grantees that served to over 900,000 patients. This is also some background information about public housing demographics. So as of 2021, there were 1.5 million residents in public housing and 2 persons per household. 91% of them were of low income, 38% were disabled, and 32% were female head in households with children. 36% were children as well, and 19% were elderly. Also, in terms of race and ethnicity, 52% were white, 43% were African American, and 26% were Latinx. And now we'll pass it on to Dr. Kevin Lombardi, who will go over today's objectives.
Hi, everyone. Today is going to be a very practical session. The cornerstone will be a comprehensive case study. It was recently published, and we will go into the details and look at the frameworks utilized in this study. So we'll be examining the planning and integration efforts that support SDOH policy success, describe the workflow frameworks that support SDOH policy success, and examine and critique examples of SDOH program design and implementation. Next slide, please. Here is a shot of the case study. I do have a PDF available that will be sent out to you, but it's a very good case study and it's very recently published and goes over some very real and practical constraints that I feel many of our organizations, particularly those in rural areas, are experiencing. The framework is also applicable outside of rural areas. I thought it was worth looking at in detail. Essentially, this is a Nebraska state case study, and it involves a healthcare consortium working with Active Care, a for-profit company who created a platform for their CHWs. The case study is lengthy, and we'll be taking a truncated view of it today. We'll review the pre-intervention assessment that they used and why I think it was effective. 2, we'll review a model for outreach and screening. We'll talk about the role of CHWs in SDOH program implementation and discuss some of the so your attention participation is appreciated. We will have discussion sessions throughout the case study, and I'm looking forward to hearing and seeing what you all have to say. Next slide, please.
And then sorry, Kevin, so before we continue, I'd just like to remind everybody to please mute their line. That way we don't have any interruptions throughout today's presentation. Thank you so much.
We start with the case study, and it's a multiple choice question based on our example. A Nebraska-based healthcare consortium seeks to better address their SDOH patient supports. To do so, they perform a review of the literature and decide to expand their existing CHW workforce to better meet patient needs. No other program preparation was performed. Which of the following is an appropriate next step? A, perform an assessment of the needs and demographics of their community. B, design a program based on patient needs identified by staff. C, design a program based on the interests and skills of health center staff. Or D, hire and train additional CHW staff. Please take a minute to select your answer. Okay, next slide, please. So the answer is A, perform an assessment of the needs and demographics of their community. A common misstep in SDOH program creation and implementation is that organizations often rely too heavily on their working knowledge of their communities to plan programs. This knowledge is a necessary prerequisite to program creation, but has limitations when used without appropriate consideration of community needs and demographics. This can be accomplished in a variety of ways that we will discuss in the succeeding slides. But on using case studies, early in the question, it mentions the use of a review of the literature in order to see what's being done and how it can be used. Reading case studies and reading studies on the types of programs that you would like to use is an important step in the creative process and in the program design process. And that's where I'd recommend, and where the literature recommends, most people start. Even for those of you who have a good grounding in the literature, new things are coming up all the time, and you'd be surprised how many problems can be fixed by just doing some reading and enjoying the details. But on using case studies in SDOH specifically, previously there was little information available on how to appropriately address SDOH needs at the community level. Fortunately, a wide variety of case studies and scientific literature is now available, and this helps to provide a framework. These can provide a playbook on how to perform assessments and other key steps. In particular, for health centers, case studies can be the most helpful. These provide details about how a program was designed and what its outcomes were. This allows you to take a modular perspective and sort of take the things that you like. For example, if you read a case study and you really like the screening procedure they use, that's a good thing to take and put aside. Or you really like the assessments they use, take and put aside. The way case studies are written allows you to do this, and it's really like getting a playbook. When utilizing these resources, please keep in mind the unique characteristics of your community that may limit their applicability. For example, a Nebraska-based study may have limitations if copied and used in South Florida. In the following slides, we'll look at the details of the Nebraska example and critique its application. Next slide, please. Now, to go back to the overview of the Nebraska study, we have a health center that's based in a rural community, the Omaha area, that has about 30,000 people. It has many of the restraints that many other folks who work in rural communities may also have: issues with transportation, elderly patients, veterans, and so forth, needs that are not appropriately met at the time, but need to be met. What they essentially did was work together with a private company who created a CHW workforce tool and used that to create a CHW intervention. Essentially, the health center did a survey of the community, identified the areas in their county that had folks that had needed SDOH support or were likely to need SDOH support, and they called them, texted them, and emailed them, and they invited them to join the program. In this program, a CHW worked with a patient or a person to basically network them to the things they needed based on established goals that they made in a clinical interaction together. It's a great case study on this particular use of CHWs, and we can learn a lot by looking at what they did and what was successful. But looking at sort of the main framework of what they used, this is a organization that does not have a strong SDOH present currently that is looking to make one. And this is the process that was used, and this is stuff that's echoed in the literature and so forth. So this is a literature-based and science-based assessment. Essentially what they did is they started with a community assessment. Using things like census data, county data, and so forth, they were able to identify the places where SDOH supports were needed. Now, one of the most important things in determining someone's access to services as an adult is how much, what zip code they live in. Sorry, in children as well, what zip code they live in. They use that information and other things about health conditions, Medicaid use to identify folks that were likely to need this help. They specifically prioritized 7,000 of this 30,000 who were Medicaid members and who lived in the zip codes that were most at risk. So that was the community assessment they started with. With that information, they performed an outreach and screening using their community health workforce. Essentially, they were able to get the contact information from the county of all of these individuals, and they performed a multimedia communications based on that. Essentially, all the people in these zip codes that they could get information on got a call, got a text message, got an email, and got a direct mail. And the reason it was like that is because folks respond differently at the individual level to different types of channels. So that was an effective way for them to communicate with folks. When folks contacted them, they performed a screener, essentially using an SDOH tool to identify which things people had challenges with, be it transportation, access to insurance, access to housing, access to other social supports. These are the things that were asked in their screener. Now, based on that screener, they would ask themselves a question. Does this individual require SDOH support? It was a yes or no answer. And if it was a yes, they were enrolled in the program, and thousands of people were enrolled into the program. When someone was in the program, a person was enrolled, they would receive from the CHW coaching regarding key resources, positive reinforcement, and trauma-informed care to help them meet those goals. So outreach and screening is complex. For those of you who are involved in program development specifically, or for those of you who are on the ground, in the absence of a guiding framework, it's easy to get stuck in this stage just because of its complexity. Fortunately, there are frameworks available to meet the myriad of diverse needs met by our FQHC partners. In Nebraska, prior to program implementation, the community assessment gave them the information that they needed. It was a clean process that allowed them to know what individuals they needed to get and what to send them and how to find them. The outreach and screening allowed them to enroll them, and they were able to get a large proportion of the people that they contacted. So that's the framework. What I recommend with those of you who are FQHCs that may not meet the dynamics that we see here, for those that are in urban areas or Spanish-speaking areas and so forth, where this case study limits application, the frameworks are still important, and the frameworks still tell us how to do things. Because the frameworks are mostly about workforce management, and they're mostly about workforce organization. And those are the places where organizations struggle the most, and that's not just in healthcare. Frameworks give us clarity, and frameworks give us mutual understanding. Next, please. Case study, benefits and limitations of corporate partnerships. As I mentioned earlier, this is a healthcare consortium working with a private company. The private company gave them the assessments, screening tools that they needed in order to find their patients. And for those of you who work in health centers or housing administrations, I'm sure you've had had experience in the past with working for-profit companies or with for-profit companies. And there are benefits and limitations of that. And I'd like to take a moment to discuss that. In the Nebraska-based study, a healthcare consortium worked with Active Care, a Boston-based healthcare organization, to use their digital platform for enrollment and resource navigation. This resource was used by the CHWs during patient encounters. Please take 2 minutes to consider the following. What are the benefits and limitations of partnering with private for-profit corporations in these circumstances? And Fide, could you give them the participation prompt, please?
Sure.
Oh, sorry. Just where to put their comments and how to raise their hand.
Oh, yes, of course. So just make sure, you know, that you put in your responses in the chat. And if you would like to also provide your responses verbally, you can also raise your hand and your line will be unmuted.
I'm setting a timer for 2 minutes. Please take a moment to write or type your response. And if you're willing to share, I'd love to hear that. Thank you. I have a timer going. Fide. Okay, Fide, we'll just go another 15 seconds and I will call for responses.
Okay.
Actually, we have responses coming. I'll extend that a little bit to 2. I understand this is a complex question.
Mm-hmm.
Okay, before I call responses, do we have any hands, Fide? Please raise your hand if you'd like to share something verbally with us.
At this moment, we do not have any hands raised.
I see 2 responses in the comments. Could you ask them if they'd be willing to share, please?
Yeah, definitely. Michelle Diem, I'm gonna unmute your line. If we can please just let us know a little bit more about that challenge that you're presenting in the chat.
In particular, Michelle, I think you're getting to something I'm trying to get to on one of the limitations, and I'd love to hear more.
Yeah, no, it's interesting to me because they reached out to us because I'm in Omaha one time and I had a meeting, but it didn't go anywhere. We were really interested in how the referral process would work, and they didn't give us clear information on how to send patients who could use CHW support to them. We do prepare screening on our patients. And so patients that mark they have a lot of needs, we wanted to know how we could connect it to their CHWs to case manage. And they didn't have a good response for us. And then they also weren't going to share information back. So if we sent a patient to them, we wouldn't know if they were helped, which is something we're really looking to, know the outcomes of the efforts. And so the partnership ended then and we didn't work with them.
Michelle, you mentioned using the Prepare tool. Could you just briefly tell our audience what the Prepare tool is? And I was wondering if you guys adapt it or you use it as printed.
So it's a social needs screener, and we did adapt it. So, a good chunk of the questions, especially demographic related, we already collect on our registration form. And so we didn't want to duplicate questions. And so we reduced it to questions that weren't already asked. And then we added a section where patients specifically request help. So regardless of what they answered before, they can tell us what connections to community resources they want. Do they want help with SNAP enrollment? Do they, need a food pantry? They can mark that for us. And those are the resource, kind of the actions we take from the form to connect patients to care.
Appreciate those details, Michelle. Thank you. Was there anything else you wanted to share with us about this topic?
No, I think in general, we were excited when they first reached out because some of our patients mark they have, 5, 6, 7 needs. And those really need a case manager, a CHW to kind of tackle because it's overwhelming for the patient, to be like, I need help with 7 different topics. Where do I start? So I think there's a need for that. But in this case, yeah, the collaboration didn't work out.
So and just to go over this and specifically, one of the main limitations with working with private companies that offer platforms is that these platforms are proprietary. And often that patient data and data related to the patient has a very real economic value to the companies and is what funds the tools. So it's a very serious and very real limitation that you should keep in mind when thinking of or having an offer to work with a private company that has a tool or a screener. There are tools and screeners that are available that are not proprietary. As Michelle's discussion about the Prepare tool tells you, some of them are very good and very validated. But working with private companies has some very real benefits as well. They're often very well funded, are able to help fund an initiative, and are able to give long-term use to their platform. These are very individual decisions that are based on health center needs and management goals, and all of them should be taken very seriously and independently. Fide, do we have some more?
Yeah, we have a lot of more feedback here. I'm gonna choose Jenny Gilmore. If you could please elaborate a little bit more on your response.
Yes, thank you. I'm basically talking about information sharing with other facilities, such as referring to an OB doctor. And then the limitation to that would be that they wind up keeping our patients and not returning them to us after the referral. So that becomes an issue where we don't want to use that referral source again. We also have a situation that just came up recently where I was asked for any kind of knowledge about colonoscopies, referring those out to facilities that may be able to work with us on like a sliding fee scale for all of our patients who have no insurance. That's been an issue. We can get the provider to agree to a very low fee or a sliding fee, but the facilities are not as willing to. So that's a big limitation for us. And it could be a benefit if we could have worked something out that way.
Now, Jenny, if you don't mind giving me some details, you work at a FQHC, a housing administration or associated healthcare organization or something?
Mobile County Health Department.
Okay. Now, this is a very important thing that you brought up is that, healthcare is a competitive environment. It is a business and it is a competitive environment. And many of us have opinions on if it should or shouldn't and where that should go. But those are out of scope of this, of course, and it is still a reality of the environment that we need to adapt to. The issue of stealing patients and so forth is something I've heard before, and it's a shame because it's an active barrier to collaboration, essentially, is what it is. And I think points to the importance of long-term relationship building within healthcare networks. Building and leveraging those relationships in order to work together to stop those competitive interactions from happening is important. And the answers are very individual at the health center community level. Looking at the organizations you're talking about and why they may be doing that can, I think, answer in questions as to how to address it. It may be an answer like more communication and more active collaboration, coming to the table with them with ways your system could help their system. The building blocks for collaboration are always there because the incentives are there. At times, our partners just aren't aware of those incentives. And for those of you who are at health departments and at housing organizations, administrations, depending on where you are, there's a lot you can bring to the table with these organizations and making things easier. And sometimes a conversation like that is necessary to make that interaction stop. But this is a very serious thing that happens all over the country. And, I'm sorry for that frustration. Jenny, was there anything else you wanted to add before we move?
But that's it. Thank you. I appreciate your time.
Thank you. Fide, could we do one more, please?
Yeah, for sure. Brooklyn Booker, would you like to share with us a little bit more about your response?
Sure. I will preface this just by saying I am kind of a third-party input person right now. I don't have direct access to these types of programs with ours that we're growing, but I did want to speak on just some things that I've seen with some of our community partnerships with, resources, is that as time moves forward, the ability to access certain resources has become limited. Basically, they will continue to kind of decrease the amount of people they can see, or they will slim the criteria down to such a narrow point where it is no longer accessible to a large amount of people in order to try to conserve that resource, which is beneficial because you get more pointed care or, the most appropriate resource. However, once that kind of fills up, then that resource is completely taken off the table for an entire population of people who also need that.
So if I'm getting this correct, Brooklyn, using the resource creates a kind of dependency on the resource, and then when one's asked to pay for it, creates a burden. Am I correct?
Yeah, and also I think a part of it is profiting off of the demand for whatever that resource is. You don't have this resource in excess. And so once it's been identified and given to however many people that it, should be going to, then it's no longer on the table for others to use. It can just be very difficult to navigate once it's already so marginalized.
And so thank you, Brooklyn. I appreciate that. And I think it's to the importance of a couple of things. One, the limitations of these partnerships, and where the benefits sometimes can be things that you pay for down the road. But the importance of the contract process and the partnership process with these companies. You bring up some very real concerns that maybe, depending on the contract, can be addressed. When health centers and private companies work together, they work on a contract basis, and having a good understanding of how you can shape the contract to the benefit of your patients is incredibly important. And that's often, in FYI, that's something that's done with an attorney who understands these things very well. And to highlight the importance of when you are working with a private company, make sure you understand your contract well and what it bodes for the future of your population. That's something that should be a primary concern when looking at that. These documents are often complex, and having someone who is in the know review them can help identify issues that are important that you're going to pay for down the line. So thank you very much. And for time's sake, I think we will move to the next slide, please.
Thank you, everybody, for your responses.
So here is the use of the CHWs in this particular case study. And I think it's a good framework for the use of CHWs outside of the exam room. I'll then be going over something briefly that's a framework for using them in the exam room. But I think it's important to separate those as a dichotomy of two different ways to use CHWs, because the beauty of CHWs is they can be so flexibly used in workflow. And because of that, we can find creative ways to make the investment in them pay off as much as possible. The Nebraska example gives the opportunity to examine in detail what an effective CHW use policy looks like. CHWs are community action experts. Their colleagues and their workforce should reflect their unique capabilities and respect their role in impacting patients' lives. Medicine is very hierarchical. Our respect for our patients and communities should be the basis for our respect to our colleagues as well. Mutual respect at work means mutual respect in the exam room. And I say that because tension between clinical, non-clinical, social, and non-social staff has been an issue at every single health center I've ever worked in and every single hospital I've ever worked in. It's a prevailing thing that we inherit when we start working there. Important thing to note, and moving on to the framework. Looking at the Nebraska example, it's valuable because the organization framework gave CHWs the tools they needed to do their jobs appropriately and effectively. The framework took advantage of their unique skills, which is knowledge of the community, ability to build rapport with the community, and knowledge of the key assets in the community. The framework is as such. There were 6 main steps. The CHW would start in the intake process, focusing on relationship building and networking. And it also included the screening results, CHW reviewing the screening result and thinking of programs in the community that would be useful, co-creation of goals with the patient to specifically link them to resources and give them goals for getting and using those resources. And this process was used to build rapport and to bring the patient more closely into the program. Goal achievement. Patients, as many of you may know, patients and persons in the exam room and out respond very well to a coaching dynamic in these sorts of circumstances. The CHWs in this study were trained to take a coaching perspective and really functioned as life coaches in many ways for these patients. That was a framework that worked in this community and led to a lot of people having success, a disproportionate amount. And I believe that perspective was a very important part of it. The follow-up engagement was also very structured. The persons would receive a call once a week, and in that call, the CHW would go through the details of their goals and things the individual was supposed to do or was going to do, and just go over it in a non-judgmental and trauma-informed way. That kept the patient focused on the goals and gave them the encouragement and networking that they need. Through those interactions, persons were able to be linked to more resources and more diverse resources. Third is the navigation. In almost every application for CHWs, navigation is a primary aspect. In this case, that was the relationship building and the networking to services during once-a-week calls with the individuals. And as I mentioned, there was a coaching relationship that was developed between the CHWs and the individuals they were working with. People respond very well to being coached under the right dynamics, and a judgmental, diversity-minded, and trauma-informed dynamic is a great way to encourage people to respond well to coaching. And case closure. As I mentioned earlier, initially, the CHW would set lists of goals to be obtained in the program. When those goals were all met by the agreement of the CHW and the person, the case was closed. So that individual walked away, having been linked to services, and more importantly, being given the skills and the mentorship needed to be able to network these services. For those of you who do this for a living, it shouldn't be a surprise that these systems are incredibly complex. They confuse and they frustrate our patients. Helping them to be independent isn't just an issue of networking to services, it's in coaching them how to use those services. And this case study was a good example of using the CHW workforce to do that. Next, please. Now, before we go, any questions on the use of CHWs outside the exam room? I'm about to go through an in-exam room example. PD, let me know if there are hands. So just to look over a model for integration of CHW and social services into outpatient workflow. At many organizations, it's not effective or efficient to have a separate CHW workforce that is out doing SDOH work or social work. For many organizations, it makes more sense to put them right into the exam room itself. And often organizations that do that, I'm thinking of a couple in particular who have done studies on clinician satisfaction. And for organizations that integrate CHWs into their workflow to do assessments and to do network for services, retention of staff was improved. So in this model, we have a clinical interaction of a physician visit at a PCP. The CHW would perform a standardized SDOH assessment like the prepared assessment or something adapted to your local health center. The assessment is performed using the standardized tool. The tool results are added to the patient's file or entered directly into the EHR, and the patient is educated regarding resources and access. The patient then goes to see the appointment with the physician, who makes referrals and integrates results into care. Physicians often are limited to 15 minutes when they're seeing their patients, and often they have just as many chronic issues as they have minutes to address them. That restraint makes responding to SDOH issues very difficult because in the physician's mind, they often fall lower in priority than, say, addressing diabetes or addressing COPD. But if a physician were to start an assessment with an SDOH screener in their hands or in their EHR that indicated them what resources or support the patient would be receiving, this is information that can be integrated into care and integrated into the coding of the patient visit and the resources, the medical resources the physician chooses to give. Additionally, physicians can push people up more to more intensive social services interactions if they meet those criteria. And the patient can then be seen again by a social worker or a case manager or a CHW that can help work with them and create a long-term relationship to reach those goals. So both of these models, both the Nebraska and this example, we have CHWs working with folks and coaching them to reach SDOH benchmarks. And that's something that can be used both in the exam room and by a separate CHW workforce. Next slide, please. Fida, could you read the discussion question, please?
Of course. So community health workers are an indispensable aspect of health center service provision and efficient management. However, CHWs are a relatively new profession. As a result, the frameworks and recommendations for their effective use are less clear than other professions such as nurses and caseworkers. So now we're going to take 3 minutes to answer the following questions. What have been the main challenges in maximizing the use of CHWs at your organization or organizations you have partnered with? And how have you or your organization navigated this?
So I have started the timer. I'm very looking forward to your responses on this. I know we have a variety of CHWs or folks that manage programs worked by CHWs. Let's share our collective knowledge on this because this is a consistent challenge that our health centers are seeing everywhere and that I've experienced myself. Oh, and same system. If you could write or type your responses, hands raised if you'd like to share. And if you put something written in the chat, we'd greatly appreciate it. Thank you.
Thank you, Rebecca. In just about 1 more minute, we're gonna unmute your line.
1 more minute now.
Okay, so it's been 1 minute. Rebecca, I'm gonna go ahead and unmute your line now.
Good morning. Can you hear me?
Yes, we can hear you.
Okay, excellent. So some of my challenges as a CHW in my organization has been health literacy of my community has been like the number one thing. But most of our partners are really great about referring clients out to us. But their health literacy, it's not, to work through the case is almost impossible sometimes. And they're referring to us and they keep referring to us, sometimes 20 cases a month, and there's only 2 of us in our organization. And only one of us is a Spanish speaker. And they're very complicated cases. It's not, okay, here's the food bank, here's a primary care physician, here's some specialist. Why don't we sit down and talk about whatever your chronic illness is and work through that? And, oh, you're doing better, great. If you need us again, it's almost like there's no end to their complicated needs.
Mm-hmm.
And there's a lot of them and only 2 of us.
So thank you for sharing that, Rebecca. You bring up a number of important points here. And I have a quick question for you. You said you get referrals. Do your CHW, the 2 of you, do you work in a separate office and manage the patients as they're given to you? Or are you in the exam, before the exam room or after the exam room or somewhere in the client visit?
So we've kind of based on our specialties. Which I don't know if she's on the call, she can jump in anytime. But Wendy kind of specializes in helping our clients with their Social Security Administration issues. I'm mostly the translator, and I deal with a lot of the kids that get referred to our program. I was a pharmacy technician for over a decade. So some of those pharmaceutical issues just kind of land in my lap where, I try to straighten them out as quickly as possible. We've got a primary care clinic that refers to us. We have a local hospital that refers to us. We have a outreach center called the Hardy Health Center that they're our food pantry and do a number of things as well. They refer to us. So we have 3 different levels into our organization.
This is a very interesting. This is both an interesting and a common issue that we hear from all over the country. And the primary problem here is that CHWs are staff members, and many of their services are non-reimbursable by insurance, Medicare, Medicaid.
Yes.
So we're restricted. We can't just get them paid for in many cases. In the organizations that have the largest CHW workforces and have had the most success with them, in speaking to them, there are a couple of things that are really common. And the first is they've found a way to make the economic argument for CHWs. The SDOH argument is so clear that everyone understands it. If they don't understand it, just give them one of the papers, and they will understand it by the time they read it. It's very clear. It's very well studied. The economic argument is harder. When I spoke with the management at the University of Illinois associated FQHC, they have a very large CHW workforce, and they've done an internal study that have showed that when they have CHWs working in workflow, that the doctors are happier, the nurses are happier, and they see more patients. And why? Why? We ask ourselves that question when we see those conclusions. And the answer is that CHWs and the work they do accomplishes things that take away frustrations from these other people. If SDOH needs are being met, then they're not going into the exam room with them fresh. They've been addressed, or they are being addressed. So that takes time away that they can focus on the diabetes and COPD, or whatever the health issue is. Also, raising the efficiency of other workers and raising the workforce retention of other workers is an economic argument for CHWs. If having CHWs in the exam room, or having a good workforce that is CHWs, saves you from losing doctors and nurses and makes them more efficient and happier, the CHWs have paid for themselves and then some. Now, there are studies that have shown that, and if you'd like to contact me, I'd be happy to give them to you. Oftentimes, CHWs are a newer profession, and for those, many people who are running FQHCs have been doing so for 30, 40 years, and they have seen things evolve throughout and have a good understanding of what works and what doesn't if you come to them with the right argument. And often in my interactions with FQHCs, showing them some of the data on how much CHWs can save you in efficiency of your clinical interactions and so forth is enough to make them consider changes. So looking at your situation specifically, you're getting a lot of your referrals from a PCP and from a couple of hospitals. You only have 2 staff members, but if someone gave me your situation and says, I can give you 2 more staff members, where would you put them? I would put them in or close to those organizations. I would put them in the PCP office, and I would put them in the hospital, and I would find ways to make a partnership with those organizations so the CHWs could help the organizations and the organizations could help the CHWs. There's potential for collaboration, and that's a recommended framework to look at that. But to give a more overarching view, CHWs are often non-reimbursable. That is something that is likely to change in the next 5 to 10 years. There's a lot of push here in Washington to make that change. And we're keeping our fingers crossed. So hopefully you get a lot more support in the future. But in the meantime, there are a lot of arguments you can make for increasing your presence. And I'd be happy to talk with about those in private or together if you want to email me. Fide, if we have any other hands.
Yes, we do.
Thank you so much for your input.
Thank you so much, Rebecca. So now I'm gonna mute the line for Wendy. Or I think your line is already unmuted.
Oh, yes, it is. I'm sorry. Yes, and I am the number 2 person in that group that Rebecca was talking about. But one thing that the medical profession needs to understand is that becoming a CHW requires multidisciplinary roads of education that the CHW has to go through to learn how to kind of interpret the medical terminology and break that down to be able to educate the client. We need to understand some of the ins and outs of all the funding or things that are available out here to us financially, because the primary bunch of our clients don't have insurance, or if they do, they are underinsured and can't afford to have testing that's required of some of their illnesses. Can't afford a CPAP machine, can't afford their diabetes medicine. And while I know there are a lot of ways to get around the insulin and things like that, we have to really investigate and find other paths to finding the resolution to solutions to some of these issues. I mean, what we do, we advocate, we coordinate, and we educate, and then hopefully we can close the case with the knowledge that our clients have made progress. But there are a lot of ways that CHWs are needed, and I think that rather than have one CHW per a patient, that it's very important that we have teamwork. Whereas Rebecca said, we have different strengths, and our organization would have the client. However, each one of our areas of expertise would be brought in at a certain time, at the appropriate time, to meet the needs of the patient.
Yeah, so thank you for sharing that. It brings up first, I think I need to start with an apology, because I was one of those clinicians once. And the reason was I just didn't know. CHWs are new, and in my medical education, they didn't even come up. I never heard community health worker once. I didn't even run into the concept until residency when I saw them. And it was by understanding what they did that I started to see how much they could help me. And you're talking about collaboration, essentially. And CHWs and clinical professionals, we are like this. What we do affects each other totally. And working together and facilitating that collaboration we're seeing it all over the country, Wendy. It's happening everywhere. It's a culture change that takes time, and it really requires people like you and your colleague to be at the table. And that can happen in a variety of ways. Some organizations put a CHW manager or representative on a hospital board, an FQHC board, or an advisory board. I think that's a great place to start, because that puts you at the table and having the conversation. And from the perspective of managers and administrators, the CHWs have very important opinions about things, and they see things the first. If something is happening in a community, it's likely that the CHW is going to be the first folks to hear about it. So they're really a part of the neural network of the hospital and of the organization. And that warrants a seat at the table. Many organizations are doing that. And I think what you'll see over the next 4 or 5 years is institutional recommendations that CHWs be involved specifically as stakeholders at the management level. And for those of you who are in a management position and manage CHWs, finding appropriate ways to put their input into your management and have access to the information that they have is an important tool in program development and proper management. Because the bottom line is all the data shows is when we better integrate CHWs into flow, even when they're not reimbursable, the efficiency payback is more than the cost. And if anyone has questions about that or would like the data, I'd be happy to send you some examples. So thank you for that. Do we have any more before we move on? Oh, we are close to 55, so I think we need to. Yeah. Thank you all for your input on this. Great to see so much excitement about CHWs, and thank you. Okay, so I'm just going to go over some resources. For those of you who are involved in patient-centered and person-centered care, firstly, thank you for your service. You're doing God's work. Thank you. What I'd like to show you is some resources that might be great for your community. We've had some recent collaborations with the Legal Service Corporation, and I got familiar with some of their resources. For those of you who are involved in program development, they have resources on legal needs and how to get legal needs fulfilled by patients that may be helpful. Eviction, debt collection, and other legal issues are primary social determinants for folks living in communities throughout the country. So if you follow the resource link to LSC website, you can see those. I've given you the link for these 2 specific tools, which I thought would be helpful in program design. Next, please. Collaborations are the cornerstone of what we do, period. Be it collaborations inside of your institution between CHWs and management staff, nurses and doctors. different organizations. Envision centers and job quest sites are good places to look if you're seeking places to economically empower your patients. We have an epidemiological map that maps them throughout the country. There are many more details than those showed. And if you follow the mislabeled resource link, you can find that our maps. Next slide, please. And another for legal resources. The National Center for Medical Legal Partnership has tools on disability and chronic disease discrimination and how to prevent it. And you can find a link to these resources here. These are all resources that I've looked at myself, and I've met the creators, and they're very good and very effective when put into the right context. And let me just look at my slides to see where we are, Fide, excuse me. Okay, could you briefly go to slide 24? Integrating the when Wendy and I were talking a moment ago, we were really talking about integration of SDOH policies. Community health workers are the cornerstone in many places of SDOH programs, and being more effective at doing SDOH programs and addressing the SDOH is really a way of thought. It's a culture. It's something that needs to permeate your organization structure and the interactions between colleagues, superiors, and so forth. Next week, I'll be going over a case study that looks over how an organization that was interested in SDOH set the necessary framework and foundation necessary to actually do something, and had a lot of success. So we will do that next week. If we could go to the, I'll give you a number in a moment, excuse me, slide 27. For people who are interested in anything we've spoken about today and how it could affect your organization, I do pro bono consulting for anyone who is a member, who is connected to an FQHC or a housing administration or a public health entity. So please contact me. I'll be happy to put an hour aside with a week's notice. And in particular, if you're interested in any of the following things, please contact me if you'd like. Next one, please. So we have a minute for questions if anyone has something pressing. And Fide, if you could tell me if we have any hands, please.
For sure.
Okay. Thank you all for your service to our communities, for your thoughtfulness. This is a difficult subject, and I've been very pleased by how honest and open everyone has been about their observations, frustrations, and thoughts. Thank you all so much. And for those of you who are in an emergency care setting or in a primary or urgent care setting in places affected by the wildfires, good luck. I'm sure there will be quite a bit of asthma exacerbations and COPD exacerbations in the next weekend. So thank you for your service to that and for your response to that. Thank you so much and have a good day.
Thank you, everyone. And just before everybody leaves, just one quick reminder about our next session next week on June 14th at the same time at 1 p.m. And also just another reminder to please fill out our post-evaluation survey. And this is our contact information. So we're just gonna stay in the line for a few minutes.
I'm speaking with someone just after this, so I'm gonna stay on. Peter, you can stay if you'd like to.